a few times recently. This time I thought I would give it a slightly more interesting title. So the rise of CBTi for the demise of hypnotics in community dwelling older adults. So this really is a presentation where we're focusing on those who live independently, who are 65 and older, who for the most part are doing reasonably well. They don't require some sort of advanced care. They're not in a nursing home. But they are under the care of usually a primary care provider and may or may not be seeing one or several specialists. So make sure I got my attention here. All right, so there's 2 or 3 slides. Since this is the penultimate presentation for the year, you may have seen slides like this in terms of the disclosures. I have received some research grants that are relevant to today's presentation. And I'm going to talk a lot about something called Sleepwell. And I'm the co-developer of Sleepwell. So just want to let you know that it comes from a long-term love with Sleepwell that I'm presenting on that today. And in terms of conflicts of interest, you may have seen this before. And then the last one. The materials that I am presenting today have gone through quite a few CPD reviews in one way or another. My learning objectives for you really are to be able to support patient and client access to and the use of self-guided cognitive behavioral therapy for insomnia resources. So I'm going to introduce you to those. And to support your ability to help motivate and enable patients to be coming off of their long-term use of sedative hypnotics. And then hopefully along the way, you'll be identifying what your own needs are, knowledge and ability, so that down the road, you'll be able to coach or support. So maybe right off the bat, I could say, my goal is not to help you turn yourselves into the providers of cognitive behavioral therapy for insomnia, but to know how to help your patients access it, especially in the self-guided form. So it's no surprise to anybody here attending today that sleep complaints increase with age. This is an old study, but a good study that demonstrates the rise of sleep complaints over the years, where we don't have those that are over 80, but you can probably estimate that it extrapolates to a higher level, probably 30% or more. What happens as we age? There's a few changes that are really considered to be expected or natural changes. It's not something that indicates there's some sort of medical problem, but a change in sleep quantity and quality. We have a substantial decrease in the amount of time spent in deep sleep as we get older. And this really happens in the middle adult years and just extends all the way through into the senior years. Sleep becomes quite fragmented. Our sleep efficiency often suffers because of that. And circadian rhythm changes also occur at the same time, such that melatonin release can happen a bit earlier, driving that need for sleep in some individuals to be earlier. And then they're waking up well before the sun comes up, and they can be quite frustrated because of that change as well. These are normal though. And I want to emphasize that none of these are requiring a medical intervention because they have occurred. First question, what's the first line recommended treatment for insomnia disorder, also referred to as chronic insomnia? And the definition's quickly indicated there, but most nights you're having difficulty sleeping, you have daytime distress associated with it, and it's been lasting for 3 months or longer. And the answer comes from a few different sources. So the American College of Physicians in 2016, I think, were really the first to come out and boldly say that ACP recommends that all adult patients receive CBTi, cognitive behavioral therapy for insomnia, as the initial treatment of chronic insomnia disorder. So imagine that, the initial treatment of CBTi. And I think you can see that that is not at all what is happening. Usually the initial treatment is some sort of pharmacotherapy. And CBTi is either never thought about or thought about well after what really would be chronic pharmacotherapy for individuals. The European Sleep Research Society mirrored what the American College of Physicians came up with a year later. I think the second part of that, a pharmacologic intervention can be offered if CBTi is not effective or not available. And what I hope to show is that there really isn't an excuse any longer about it being not available. And then a third source that I'd like to bring up is the work that has come from CSMH, and I see a number of people who are present today are part of that guideline itself, or were related to other guidelines that came out of that same work. So this one's related to the benzodiazepine receptor agonist use disorder, and the recommendation, number 2 recommendation is first-line treatment of insomnia and anxiety disorders is some form of CBT. And the benzoreceptor agonist should only be considered in the management of insomnia after non-pharmacologic interventions have been tried and have not worked out. So just to make sure it's all clear that we're all sort of speaking from the same page, where I want to situate ourselves today, we're really focusing on people who live in the community and are receiving most of their care in primary care. Community pharmacies mentioned there specifically because of the need for deprescribing and the important role that they play. So there's a role for CBTi in community, in primary care. And we often want to drive people down to self-directed insomnia care. And for those who need more advanced interventions, referring them to trained CBTi providers or even more specialized care with behavioral sleep experts. So the role of the community pharmacy really would apply in all cases when there's deprescribing of sedative hypnotics. And we really want to be able to help people lead that approach. So moving them down in that step care approach. I'm just gonna hope this goes. I'm going to mute you for a moment. Good, somebody picked up. That one was out of my control. So mysleepwell.ca is a website that I would encourage you to take a look at. You can take a look at it while we're presenting today. One sort of, it's not hidden, but it's not the easiest thing to find, is the research that supports CBTi. So the website's really for everybody, healthcare providers and people who live with insomnia alike. And what we provide in there in a couple of places is links to the research itself. And we've added the research, and there's probably 100 entries. This is an extremely well-researched area. And in this slide, it just exemplifies for whom the studies have been conducted in. These would be randomized controlled trials across the age span, so older adults, adults and adolescents, through different platforms, one-on-one with a therapist or with a group treatment, or whether it be bibliotherapy where you're using a workbook yourself or online or using an app. And then individuals had a variety of different comorbidities, whether it may be a mental health comorbidity or physical health comorbidities, who were involved in these randomized controlled trials. So what is CBTi? It's quite a bit different than CBT for anxiety or CBT for depression, for example, or PTSD, where some people say, is it even really a cognitive behavioral therapy in and of itself? The vast majority of emphasis is on the top 2 items where there's a lot of impact from the top 2 components. So stimulus control, which most of you will be very familiar with that. If you're not tired, don't go to bed. But once you're sleepy tired, then get into bed. And if you wake up in the middle of the night and you can't get back to sleep after 15 to 20 minutes, please leave the bedroom and go back to bed when you're sleepy tired. And the same applies when you first try to get to sleep at night and your mind starts to race. Bedtime restriction therapy is also probably more well known as sleep restriction therapy, but that terminology doesn't go over well with a patient population who can't sleep when you say, now we're going to use sleep restriction therapy. But I am going to take a couple of minutes just to go into that in a bit more detail. Sleep hygiene is something that people probably have already tried. If you have chronic insomnia, you've probably tried all sorts of things that will improve your sleep hygiene and you're still not sleeping. So it tends to be de-emphasized in most programs, CBTi programs, but it certainly is still a component of it. And then there's relaxation training techniques and cognitive therapy techniques. And the cognitive therapy techniques can be learned through books or by those who are trained as CBTi providers. So here's what a typical CBTi treatment course looks like from either a book or from an online program, from an app that you can download to your phone, or you can purchase, or it may be a free form of it. But they all tend to have something similar to this. You start off with a sleep diary, using it for 1 or 2 weeks, getting introduced at the same time to improve your sleep hygiene. But then at the next step would be to learn about stimulus control and sleep drive. Very often people have done just as much as they need to do to get their sleep back after those components themselves. Relaxation therapy and cognitive therapy will come later, but the improvements very often are seen within the first 2 to 3 weeks and can be quite substantial. And I've added on that layer of deprescribing to indicate that the CBTi itself can start after deprescribing has been initiated. So you may be slowly tapering off a benzodiazepine or Z drug. And as the person's sleep begins to deteriorate, you can add in CBTi then, or you can do them simultaneously, have the deprescribing start when the CBTi course starts in and of itself. There isn't an absolute rule around that. So the sleep diary, if you have not used a sleep diary, it would be a skill that would be required for you to even just coach a person or support them as they're going through a self-guided approach to CBTi. So to be able to ask them about how well they've been able to log their sleep on a nightly basis over several weeks, to be able to look over their sleep diary to see how their sleep has changed over time. So I'll go into that a little bit, not a lot. So as I mentioned a moment ago, the first 2 steps that really seem to have a dramatic impact on improving individual sleep are that stimulus control and sleep restrictions steps. So those are often the active week 1 and week 2 steps that follow along after the sleep hygiene. So I'm not going to go into details about stimulus control, but I will exemplify how sleep restriction therapy works. If after a week or 2, the person has decided and has been recording on their sleep diary that their set bedtime is 10:30 and their set rise time is 6:30, you take a look, or they take a look at their sleep over the last week to 2 weeks, and they identify that they are in bed for 8 hours and they're sleeping on a typical night for about 6 hours. So that's about 75% sleep efficiency, which is that ratio of time in bed and time asleep. So sleep restriction therapy says, well, let's change your bedtime, not your rise time, but change your bedtime so that you are in bed for the amount of time that you have been sleeping over the past week or 2 weeks, truly to consolidate that sleep time that they have when they're in bed. When they do that, they go through the next few weeks of gradually increasing their time allowed to be in bed. And this is where they see a dramatic improvement in their sleep consolidation, waking up less times in the night, waking up for less periods of time and being able to fall asleep quicker. It is true that people will experience a small amount of sleep deprivation in the first 1 to 2 weeks, but you can see step 1, complete your sleep diary for a week. Step 2, calculate your sleep duration and sleep efficiency. Establish your rise time and your bedtime. And that's your sleep prescription that you will reassess things after doing a week to 2 weeks. And then you will adjust your sleep time, your time in bed, I should say, to the amount of time that you are sleeping. So if you are in bed for 6 hours for the first week, if you have a sleep efficiency improve to be around 90 to 94%, then you get an extra 15 minutes of time in bed. And so gradually, as the weeks go by, you're adding more and more time to your time in bed. And you're basically retraining, you're cognitively retraining yourself to associate your time in bed with sleep, as opposed to associate being in bed with feeling frustrated and not being able to sleep. I would say, based on the data that's out there, and there's substantial data that's out there, that this sleep drive or bedtime restriction therapy is probably the most potent component of CBTi in and of itself. So if you don't feel particularly comfortable with what CBTi is, this may be a place to start to become more comfortable with it. So we developed My Sleep Well, which is a website for two purposes. One, to help people know about CBTi and how to access it, and two, how to safely and permanently stop sleeping pills. So when you go to mysleepwell.ca and you click on the CBTi part of the menu, you will go to learn about CBTi. So there's kind of a question answer format as to what CBTi is and how you get started with it. Sleepwell Recommends is the ultimate goal of the website itself, because it's recommending specific self-guided management approaches, whether it's bibliotherapy or online programs that walk people through CBTi in and of itself. There are these links, which you can see each has an icon associated with it, which will give more background or more specific tools in and of itself around these different components of CBTi. So what do we currently recommend on Sleepwell? There are a few books that are true CBTi books. So here's the first one from 2009, 2016, and the second edition of Sink into Sleep, which is a book that I'm most familiar with and recommend quite often, written by a psychologist at Queen's. So it's in its second edition. There are different apps. This app tends to be the one I go to because it's most accessible and quite inexpensive at $40. And then you can also get access to a therapist who is trained in CBTi, 30 minutes for $100, and possibly your insurance may help you cover some of the costs of that. And they recommend 5 sessions. So a CBTi program with Halio, which is a Montreal-based company, is about $500. So that's a quick overview and introduction to CBTi. And now I'm going to try and help you with learning objective number 2, which is how to motivate and enable the deprescribing of chronic use of sedative hypnotics. So across the land, and I do see that we have people from outside of Ontario as part of this, so you may want to take a look and see what the CI data says in terms of the prevalent chronic use of benzodiazepines and Z drugs. So this includes zopiclone and other Z drugs, as well as all of the benzodiazepines. And right away, what probably jumps out at you is the high numbers from Atlantic Canada compared to the lower numbers from the rest of Canada. Saskatchewan by far is where we want to have everybody move towards, with its low rate of 4% chronic use of benzodiazepine receptor agonists. New Brunswick, where we're doing a randomized controlled trial, is dramatically higher. So we're recruiting individuals, and I'll just mention very quickly at the end about that study. And if you're like everybody, you'll say, why is it so different? And I will tell you, I'm not sure. Maybe it's prescribing culture or other things over time that have caused such a difference regionally. So can I motivate you to motivate your patients to think about deprescribing? So first, looking at how effective sleeping pills are. This is placebo-controlled trials. How long does it take you to fall asleep in a placebo-controlled trial based on your own subjective time to fall asleep after 4 to 6 weeks of treatment? And the difference is, subjectively speaking, 7 minutes faster after 4 to 6 weeks of a Z drug like zopiclone or zolpidem. And then based on polysomnography, so it's an objective outcome measure, how much time are you sleeping longer in these kind of trials? You get 49 more minutes with the Z drug, but you get 35 more minutes with no intervention, just being in the study itself. So for a 14-minute advantage. How safe are sleeping pills? This is not going to be an academic overview. This is going to be the approach that we're taking in our research to try to help motivate people to be more interested in learning about how to reduce their use. So benzodiazepines and opioids seem to be a more popular combination, and the rate of death from overdose has increased 8 times in the last 20 years. And that's not the only drug-drug interaction involving benzodiazepines. The risks for injurious falls with especially benzodiazepines and Z drugs is increased 60%. The risk of bone fractures associated with falls is increased 66%. Hip fractures specifically, depends on the study you're looking at, 52 to 90% increase. We use these pictures as well as part of our way to incentivize people to rethink their long-term use of sedative hypnotics. Something most people are not familiar with is the association of benzodiazepines and flu-related complications. So if you are not taking a sedative hypnotic benzodiazepine compared to if you are, your risk for pneumonia when you're infected with the influenza virus is increased 325%. And if you are taking a benzodiazepine when you develop an influenza virus infection, your risk for flu-related death, this is the confidence interval, is somewhere between 240% increased to 2,000% increased. And this seems to be a humoral related effect of benzodiazepines on T cells as opposed to some other mechanism. They seem to impair their activity. Another fact that many people don't know, and I would say Canada's favorite sleeping pill, maybe not Ontario's, but Canada's favorite sleeping pill is Zopiclone. There's an interesting set of studies that have been done in the Netherlands using vehicles that have specialized technology to assess driver weaving and delay in stopping. They've done these studies with a whole variety of sleeping pills as well as with alcohol. And Zopiclone is really concerning. Not all benzodiazepines are as concerning. Zopiclone is very concerning. If you take Zopiclone and then 11 hours later, you drive, it's as if you're driving with a blood alcohol content of 0.05 to 0.8. It depends on which study and what dose they're looking at. Of course, we know things about benzodiazepines and Z drugs in terms of their effect on memory. There's those association studies on cognitive decline, but a little less well-researched is what happens to people when they're taking sedative hypnotics and they feel a little less steady on their feet because of it. There are some qualitative studies that look at individuals, and the themes are that they feel a little bit more worried about their safety during the day. They may be less involved in social activities, physical activities, become a bit more isolated because of these kind of things. More research is needed, but this may be subtle effects of the use of sedative hypnotics on individuals. And then there's the vicious cycle of medication use. And with the study we're doing in New Brunswick, I spent a lot of time on the phone interviewing individuals. And this is something that I would say is very poorly understood. When you start when you start a sedative hypnotic, benzodiazepines, Z drugs, other sedative hypnotics, they tend to work quite well at the start and decrease effectiveness over time. Very often the dose can be increased because of that, and then again lose some effect with a little bit of tachyphylaxis. And then for some reason you stop taking them. You're tired of taking them. Your physician says, I don't really want you to take it anymore. You reduce the dose or you miss it altogether. You forget to go to the pharmacy. And what happens next is you prove to yourself that you need those sleeping pills because you have a terrible night of sleep. And people don't seem to associate or seem to understand or recognize the withdrawal effects. The manifestation of the withdrawal effects, the leading manifestation is insomnia. So part of what we're trying to do with the website and with our study is to let people understand that abruptly stopping or rapidly reducing sleeping pills is very likely to cause insomnia. And the reason of having the insomnia is the medication withdrawal, not because of an ongoing insomnia problem. All right, so how do you safely or effectively stop sedative hypnotics? Which of these would you check off? So this is kind of a rhetorical question, but
I wonder, rather than making it a rhetorical question, why don't we ask people to put in the chat?
Okay, I'm hoping it doesn't animate itself.
Put in the chat which one of those you think is the right thing to do.
And I'm going to back up and set it up again. So if it's self-animating, it doesn't reveal itself.
Good idea. Thank you.
Number 3.
Anyone else?
That was a safe one, Jillian. Anybody else? I'll tell you, there's more than one.
I'm going to go the empower route here.
Well, there's a lot of right answers, I'll tell you that.
Great. All right. Thanks, David. Carry on. Thank you.
Sure. So based on randomized trials where this has been evaluated, adding melatonin, the first trial actually was positive, but 2 larger trials that followed were not positive. So I think if you remember the study done from, I think it was the Archives of General Psychiatry back when it was called that. That study was positive about melatonin, but the others that have followed don't support the use of melatonin. So what does is gradual dose reduction, adding CBTi, and an educational pamphlet. And Sid, you mentioned the proper educational pamphlet. That would be evidence-based, the Empower route. So this is just a quick overview of how you can approach gradual dose reduction. This is one way to approach it. Where you can get away with slightly larger decrements over time, but near the end you might want to slow things down with smaller decrements. And you can notice that the time interval is a bit longer between the dose reductions as you move from weeks into months. And quite literally decreasing the dose of benzodiazepine or Z drug that's been taken for 10 or 15 years can take 3 months, 4 months, many months longer. Some people can do it much quicker, but the message is to do it quite slowly to try and minimize the risk of a withdrawal rebound. On this slide, I'm introducing you to our Stop Sleeping Pills guide, and there's a companion called Stop Sleeping Pills Planner, which is an interactive way to use this guide. On the right, you'll see that I've shown sort of the overall approach where each step occurs like the step before. The size of the dose decrease is the same and the interval is the same versus the slow slide, which I kind of showed you in the previous slide. There are no randomized trials to tell you which approach to take. And I think I tend to ask patients how they would like to do it. And I may change it partway through. So I may slow down, particularly when a patient is feeling uncomfortable as we move along. So very often I may start as stairs and then move into a slower slide. So gradual dose reduction, that's critical. Adding CBTi to reassure the individual, we're not taking away your sleep therapy, we're just changing to a different, more effective, longer lasting sleep therapy. Ensure that the individual has regular contact with their healthcare providers. And I really do want to emphasize the role of the pharmacist as being somebody that they can access on a very regular basis, very often more easily than any of their other healthcare providers. I suggest consistency. So if the dose decrease is going to be on a Monday, let's do it every Monday. And if we switch it to every 2 weeks, let's do it on every 2 Mondays. But be flexible, recognizing that sometimes you go on holidays, sometimes the individual has family that come to visit for a month. So there may be different things that may cause the original plan to need to be modified along the way. What's no longer recommended is to switch people. Everybody gets switched over to diazepam, for example. That's no longer recommended. When you zoom in a little bit on the middle part of that, you can see that how long it's recommended to be decreased will depend on how long the patient has been taking the sedative hypnotic. For my purposes, almost everybody is down in the sort of bottom 2 sections in the blue area, reduce the dose slowly, where we do always recommend adding CBTi to support improving the chances for a reduction that goes successfully. This is just a quick introduction to the companion tool, which is the Stop Sleeping Pills Planner. And I'm just going to quickly show you how that actually might work. If somebody was on 2 sedative hypnotics, sequential dose reduction as opposed to doing them together may be more comfortable for the individual. Again, I ask the individuals which ones they would like to go with first, and then we tend to do it that way. So lorazepam in this case was the patient's recommendation, and then a more gradual zopiclone reduction. And for those of you who are prescribing zopiclone, I recommend that you prescribe the 5 milligram round tablet, which is very easy to split into quarters, whereas the 7.5 milligram oval tablet, not so easy to titrate it down. So just a practical tip there from your friendly neighborhood pharmacist. So how do you go from this ideal to putting it on the Stop Sleeping Pills planner? And that pretty straightforwardly is work as a team. You as the prescriber may say, well, I've got an idea of how I'd like to do this, but I don't know the pill strengths and I don't really want to spend a lot of time figuring all that out. So contacting a pharmacist and saying, could you work with me and Mrs. Smith on this kind of thing together? We may need to adjust it along the ways, but I'd really appreciate us working together as a team. And if the individual has a support person at home, a loved one, a friend who's also able to support them in that way, well, of course, they're an important part of the circle of care as well. So Sid had mentioned something called the Empower tool, and that's what we tend to call this tool. It doesn't say Empower anywhere on the front page, but it's from a study that was known as the Empower trial. So I'm going to introduce you to its contents. People in the study were sent this booklet, and this is the first page. So hopefully people can self-identify with some of the information and images in it. A quiz, answers to the quiz. The idea of those answers are to make you feel a little uncomfortable with your past comfort with the long-term use of sedative hypnotics. Some more facts around sleeping pills and how they can be potentially harmful with long-term use, especially as we get older. So a self-reflection component of the tool itself. Some information about pharmacokinetics as you age. What are ways to get a good night's sleep without sleeping pills? So, positive information. And then the anecdote or the testimonial that says, if Mrs. Robinson can do it, you can do it too. And then a guide as the back page as to how you can taper off the sedatives themselves. And that was a bit idiosyncratic in this tool. So the only thing that stands out to me that seems a little bit different than how most people seem to recommend the gradual dose reduction, which is a steady dose for a week and then decrease to a new steady dose for a week, is the schedule that was in the Empower trial, which was adjusting dose within the week, but overall gradually reducing the total weeks worth of dosing overall over 17 to 18 weeks. So what people actually got in the trial was that You May Be at Risk pamphlet that I just showed you, as well as a 18-page pamphlet called How to Get a Good Night's Sleep Without Medications. That's really based on CBTi. It doesn't ever mention CBTi, but it has the different components of CBTi all blended into this booklet that's 18 pages long. And if you were in the study and randomized to Empower, 27% of individuals, and I'll tell you, the individuals were 75 years of age on average, with about 10 years of use of their sedative and taking 5 other or more medications for physical health problems and other mental health problems. 27% were able to successfully completely stop using their sedative hypnotic by receiving these booklets by mail. Shockingly effective booklets. I've never seen pamphlets so effective before. And if you didn't receive them, some people did stop over 6 months, but it was less than 1 in 20 individuals who did stop. So a dramatic advantage of these booklets. So we're doing a study in New Brunswick. It's an RCT comparing sleep well. We've converted the content of our website into booklets, and we're comparing it with Empower. And the third group gets no booklets until the end of the study. We do an interview, about an hour-long interview at the start, and then 6 months later, we reassess everything by a second interview by telephone. So we've got about 425 people in the study as of today, so we'll be recruiting for a few more months to get the rest of our sample size up. So this is what the booklets look like on the outside. They're not on our website. Hopefully, when the study's complete, the evidence will let us know whether or not they're evidence-based, and hopefully they will be evidence-based, and then we'll be making them available on the website. So that's the Yawns, Your Answers When Needing Sleep in New Brunswick study. So coming to the end, how do we help people who are independent, seniors, living with family or on their own, and who are taking sedative hypnotics? Well, one thing we can do that's very straightforward and practical, we can recommend these two booklets, which are freely available on the Canadian Deprescribing Network website. We can have them fill out their own sleep diary and bring it back to us, and we can just talk about what their sleep is looking like and encourage them to move forward with a self-directed approach to managing their sleep, or we can help them get connected with somebody who is able to offer them CBTi directly. We can reassure them that we're not going to do this quickly. We're going to work closely as a team, working with your pharmacist. You can contact us at any time. We're not going to rush. This is a gradual process to ensure that you don't go through a withdrawal and have terrible sleeps as we go through this. You have some input along the way. So there are ranges of how quickly we can do this. Some people say, I just want to get this over with. Let's do it in 6 weeks. Other people say, oh, I'm very scared to do this. Let's go as slow as we possibly can. And we're going to be recommending that you do use CBTi. This book, Sink into Sleep, for example, is about $30 for you to purchase. And while you're reducing your medication, you actually may be getting better sleep as you go through this workbook. So we've just finished an 8-week or an 8-session program, all online. And this program was mostly Ontario physicians and other healthcare providers learning about CBTi, whether they want to deliver it directly themselves or understand how they can coach or support people to do it, as well as the deprescribing of sedative hypnotics. It will be converted into an online set of modules, if you will, and I'm thinking it'll be probably early 2022 when that'll become available. So for those of you who have had your interest piqued, there will actually be a program that you can access in a relatively easy and simple format. And based on that, we did come up with a new tool that'll be put onto the Sleepwell website momentarily. It may be good for you to read it over. It may be good for your patients to read it over, for your colleagues to have access to it. And it's just a good, relatively simple, straightforward reminder of how sleeping pills are very different in their overall role in the management of insomnia compared to CBTi. And I've just blown up the top 3 of the several ways that they compare. I think it's hard to convince yourself, let's keep using sleeping pills as opposed to CBTi when you make that side-by-side comparison. All right. I don't know how long I took, but I'm sure I took more than 30 minutes, Lisa.
You took the perfect amount of time, David. The talk took exactly the number of minutes that it took.
It did.
So thank you. It did.